of HCC. Thank you.
Good morning, good afternoon. I would like to thank the organization committee for this very kind invitation. It has been a privilege to be here. This is my first time in Uzbekistan, a place I've always wanted to visit due to many patients I've had during the last 5 to 10 years from Azerbaijan and Uzbekistan. We've had the opportunity to treat in Ankara University and now in Istanbul Bahçeşehir University that I'm currently working in. So I would like to thank again for the organization committee and the APASL steering committee for this kind invitation. Now I know that I am in front of distinguished hepatologists and gastroenterologists coming from all around the world. My talk as probably the only surgeon in the room can be a little bit provocative, but I will tone it down to a way that I hope we will find common ground to take care of our patients together. So cirrhosis in HCC is one patient, but we are trying to cure two diseases at the same time. And I asked ChatGPT, where are we with the liver cancers in 2025? So it gives me this diagram. If you don't do any surgery, the best available palliative treatment will result with failure. Conservative surgery, parenchyma sparing surgery is more popular these days, but reproducibility is limited. And advanced anatomical surgery, two-stage surgeries, and minimally invasive two-step surgeries are the hallmark of liver surgery these days. So if you go to international meetings on liver surgery, you will see this with transplantation coming in every aspect of liver cancer as a treatment. Actually, the reason I was not able to do this talk yesterday in another session, I was in the International Liver Transplant Society meeting in Singapore, and I will add some data and newest information to my slides. So I asked again, how can we increase the survival then? The result is you need to increase resectability, increase surgery, and add a bit of liver transplant into it. This is the answer with the ChatGPT. Let's see where we are. We have some obstacles to go there. One of them is, I know there's a professor here from Barcelona, but BCLC staging is a big obstacle. It only gives curative treatment options of surgery and transplantation to very early stages with the fear of recurrence and portal hypertension in mind. However, the outcome is survival. The outcome is not recurrence. This is number one trend that is changing all around the world. So intermediate stage B and intermediate stage C areas are considered no-fly zone for surgeons. I know gastroenterologists don't want us here because there's a very strong industry moving in, not only to stage B and C, but also early stages. So there's a very strong industry push in this field. And this is, again, with limited hopes for the patient. And for many patients without curative surgeries, the results are dismal, we know that. And for the surgeons, it causes a lot of frustration. Why? Because we know that the outcome, when you only apply curative surgical treatment options to early stages, you are neglecting a big chunk of patients from curative treatment options. And if we look at recent data, the curative potential is mostly available for liver surgery and liver resection. And we see this in SEER database. If you look at the survival, experts in the field, I know who are following SEER database, you will recognize it was like 5-6 years ago, it was 17% 5-year survival. Now in 2025, it is 22% for any patient diagnosed with hepatobiliary cancer 5 years ago. This is very poor. And this includes patients who are treated with resection and transplantation, which changed the course of the disease. The rest of the patients has little bit chance. If we look at the percent of cases by stage, actually it's interesting, localized and regional disease patients are more and more diagnosed early. The majority of the patients are diagnosed early. But we look at the survival is less than expected. What is the main reason? Is probably the main reason is access to surgery and transplantation is not available for these patients. And this is resulting with bad outcomes for these patients. This is SEER database data that I accessed this morning. So we are these days performing less and less surgery for cancer, despite there is strong data and evidence. Surgery results are good, better than any other modality, and getting even better day by day with new modalities in line that I will try to show. I'm not going to go through hundreds of papers. I will just show you one paper, a very recent Stanford meta-analysis of 110 studies available in the literature. So this shows global 5-year survival after HCC resection. If you see from data from Europe and Americas, you are looking at 5-year 50% survival. If you are looking at Asia, China, Korea, Japan, Singapore, and you are looking at 60-70% 5-year survival. We know that without transplantation, this is a very good chance. It doesn't require a lot of expertise. Now, these surgical treatments are available in almost every country of the world, including, I believe, in Uzbekistan. So I think we need to refer these patients to the surgery side. This is the results of the meta-analysis showing excellent 1-year survival with 90%. 5-year survival is around 55% overall on a global scale, with recurrence-free survival is poor, 35%. Why? Probably we need better surveillance for these patients, interfere early for the recurrences, and preventing recurrence through antiviral therapies. That is the subject of the meeting. So, how did we come to this point? We changed the way we look at this surgical paradigm. How it happened? Like 10 years, 15 years ago, we used to look at what are we removing? What are the criteria? How many tumors? What is the size of the tumor? Now, we are not considering any size or any number of the tumor, but we are considering if we can perform an R0 resection, and will there be an adequate future liver remnant after the operation. For conventional resection, you can remove 60-70% of the liver from healthy living donors. This is what we do in Istanbul a couple of times per week. We know that up to 70% resection in healthy donors is very well tolerated and extremely safe. But if you want to remove more than 70, 90, up to 90% of liver parenchyma, you need to do some future liver remnant modulation or modification with various methods that I'm not going to go into the details, but these are the basic fundamental principles that is guiding the surgeries now. Plus, we're using advanced technologies. Now I will show you, this is a video. I hope it will play. Would you please help me how to play with this video? Yes. So this is a conventional CT scan showing a big tumor encroaching on the right, middle, and left hepatic veins in the central location around the vena cava. So this is what the CT scan will show you, and this is what the 3D surgical reconstruction simulation software will show you. Please show next video, please. So the surgical simulation software will transfer the information comes from the CT scan. Now we can see the location of the tumor in 3D, and we can see the hepatic veins that are in the tumor that where we want to reconstruct. When we have a white cut line, like a surgical plan, and it shows the future liver remnant percentage, how much liver we will remove and how much liver it will remain. I'm not going to go to show the surgery, but just a couple of pictures that says now we understand that we can do this resection very safely only after we completely remove the liver with the tumor from the patient and remove the tumor in the back table, as you see, using different methods, and reconstruct those hepatic veins that we see using cadaveric grafts and re-implant the liver into the patient, the remaining liver into the patient. So this is called an ex vivo resection and autotransplantation. So we transplant patients' own liver after clearing the tumor from the patient. This is the TOPAZ-1 double-blind placebo-controlled phase 3 randomized controlled trial that gave durvalumab #1 position and FDA approval for cholangiocarcinoma surgery. So we know these smart drugs. I mentioned about industry. I want to draw your attention for the two-year mark. If you see 24 months over there in the Durva group, you see there's 9 patients, and the standard GEMSIS group, there's only 4 patients. Out of 340 patients who were deemed unresectable, again, these are cholangiocarcinoma patients, not hepatocellular carcinoma patients. Out of 340 patients after 24 months, there's only 9 patients in the treatment group and 4 patients in the control group. This is giving the significance. So I will show you again for the same cohort, our international cohort of 40 patients that come from 9 centers all around the world. I will just show the Kaplan-Meier analysis showing almost 45% 5-year survival. So if you are the patient, which pill would you like? Would you like the smart drugs, or would you like the opportunity to have an expert in a surgery in an expert center by an experienced team? And surgery nowadays is not only about cutting, it's now an important downstaging modality. We are operating the tumor surgery, we are downstaging the patients by removing macrovascular invasion from portal veins and resecting the tumors. When there's a recurrence, the patients are now having still transplant option. This is an important way. We know transplantation within Milan criteria provides excellent outcomes, but very few patients are within Milan criteria, and it is very restrictive. We need to downstage patients to be able to transplant, and there's a recent randomized control trial from the Milano group showing excellent results with downstaging. What is downstaging? This is Francis Yao showing reduction in size of tumor using locoregional therapies. So surgery is one of the locoregional therapies these days to downstage and bridge these patients to transplantation. And I will show you one example of our colleagues in India showing macrovascular invasion with portal vein tumor thrombus using local ablation strategies. They were downstage, and the downstage group have excellent 5-year survival of 65%. Again, you can resect, you can downstage. The best results come with transplantation. This is WHO data showing less than 10% of the meat in the world is met by transplantation because of significant global organ shortage. This is a subject for big debate, and now a recent paper from our colleagues in France in editorial in Annals of Surgery says that with the transplant oncology concept, there will be a never-ending increase in demand for liver grafts. What does it mean? It is not only hepatocellular cancer anymore. We are looking at colorectal cancer liver mets. We are looking at cholangiocarcinomas in selected patients having excellent outcomes with liver transplantation. So this is coming, this is in line. So what is next? I want to show you the latest technology we developed in Istanbul. Please show this video. Would you please start this video? Excuse me? Yes. So this is the 3D surgical simulation in the goggle. You see there are a number of goggles, and I'm communicating with my friends in Singapore. We are talking about the surgical plan, and now we're going to do, this is a living donor operation, and living donor 3D surgical simulation is put on the liver, which is called mixed reality, with augmented reality plus real life makes mixed reality. We look at where we can't deliver, and then at the end of the day, the surgery becomes much more reproducible, safer, and understandable for many younger surgeons and surgeons in training. So we have one answer with this global organ shortage. This is rapid procedure that has been designed in the last 5 years, and I will conclude my talk with the rapid procedure. What is rapid procedure? This is the historical evolution of two-stage transplantation. Started with APOLT procedure for patients with paracetamol intoxications that you need a temporary graft to sustain the patient. And then we bring this experience from combining with cancer surgery into two-stage transplantation for liver cancers. This is called rapid procedure. It has been performed first in 2016. This is a European study from 6 centers in Europe. They were able to show excellent results in colorectal cancer liver mets with no portal hypertension setting. And we did this in the cirrhotic patient. This is our first case. We did in 2019, now 6 years without hepatocellular carcinoma. She had 3 centimeters HCC in segment 7, which was not resectable. And with the rapid procedure, what you see here is a new left lobe from the resected cirrhotic left lobe. So we resect the part of cirrhotic liver and put in a small part of the liver coming from the living donor. And then when this small part gets bigger with volume hypertrophy in 2 to 4 weeks, we go back and remove the disease part. So with a very small left lobe graft, the patient with standard technique cannot have transplantation, but with this technique can have a potential curative transplant operation. This is GRWR 0.36 here. And then we moved ahead and did this operation for a patient with portal vein thrombus. So it is not only for patients with standard liver cirrhosis with low MELD score, but also for patients with high MELD score with portal vein thrombosis. This procedure can be done. This patient is alive after 4 years. And this is the first patient I showed. This was last year and 5th year follow-up, no recurrence with normal AFP. Now this is 6 years. And our experience, 5 cases in Ankara and 5 cases in Istanbul. Now 10 cases, we are leading in the world. This started as a national study in France. There are experiences coming from Czech Republic, Brazil, Korea, and this is getting wide world applications, this procedure. These are the grafts. You see the GRWRs from 0.36 to 0.51. So this converts a right lobe living donation to left lobe living donation, and hopefully in the future left lateral section, which will be increasing the safety of the procedure for the donor even more. We did a consensus conference last year in Zurich. The results are published in International Journal of Surgery. It is technically challenging. It requires living donor transplant and HPB experience, but it can be implemented across all cirrhotic liver disease scenarios with various degrees of portal hypertension. It could be a beginning of new era. Why? We have significant organ shortage, and this could be one answer. And it significantly decreases donor risk. This is very important. With small left lobes, it can potentially increase donor pool much more in deceased donors using new machine perfusion technologies. Our colleagues have developed significant technologies with machine perfusion, saving the organs in the machine, and then it can also be applied in a widespread setting in living donation. And it gives timely transplantation as a curative option for not only primary liver cancers, but also secondary liver malignancies. Graft volume becomes not important, GRWR becomes obsolete. Small for size syndrome can potentially become history when the techniques are established, which is we are working on. And anatomy is not a limitation. When I did this presentation recently in Italy, one of the hepatologists came up and said, I like this technique because this technique gives the patient selection from the surgeon to us hepatologists, because anatomy and volume becomes not important. So this was the consensus conference in Istanbul Bahçeşehir University previous year, and we did this in Zurich, and a couple of months later, there will be much more coming in Toronto in the 6th International Society of Liver Surgeons Advanced HPB Surgery Congress in Toronto. I would like to invite all of my colleagues. So I will conclude by saying Rahmat.